Hello, I'm Alice Sheridan. I'm the editorial director of nephSAP, and I'm here with Martina McGrath, who's our associate editor. And we're here to discuss hypertension with Dr. Mark Sarnak and Dr. Allison Reaves. As most of you probably know, Dr. Sarnak is the chief of the division at Tufts Medical Center and the Gerald and Dorothy Friedman Professor of Medicine at Tufts University. Mark received his undergraduate degree from Columbia and his medical degree also from P&S at Columbia. He did his residency at Mass General and his nephrology fellowship at Tufts. Again, as most of us know, his primary interest is cardiovascular disease and CKD. Certainly, I have learned an enormous amount reading Dr. Sarnak's work on this. He's also focused on cognitive function, biomarkers in kidney disease progression and hypertension, and he's been NIH funded for years, publishing more than 400 articles, and he has given invited lectures throughout the world. Dr. Reaves is also a nephrologist at Tufts Medical Center and an assistant professor of medicine at Tufts. Ali received her undergraduate degree from Cornell. We have a pair of New Yorkers here. And her medical degree from Tufts University. She completed a residency and fellowship also at Tufts. Ali's primary research interest is examining the impact of Medicaid policy on dialysis care in the United States. And we're here to discuss the hypertension issue and primarily their excellent editorial on the benefits and risks of intensive blood pressure control in patients with CKD, particularly concerning the conflicting evidence available to us. Thank you, Mark and Ali. I appreciate you being here.
Thank you for having us.
So one of my questions is, clinically, what do you do with the variable data that are out there? And you specifically focused on two recently published trials, both which suggested a benefit of more intensive blood pressure control. Has that changed your approach more in line with KDIGO? And will ACC similarly change their guideline, do you think? That's a lot, I recognize.
We thought this was an interesting topic, Ali and I, because of some of the new data and also because of the controversial, I wouldn't say controversial, but different guidelines that have come out regarding blood pressure target in patients with kidney disease. In other words, in KDIGO, the blood pressure target is systolic less than 120 versus several other guidelines, including AHA, ACC, which are closer to 130 millimeters of mercury. And I think it's just dependent on how you review the data and how you interpret the data and which populations it's applicable to. So in the guideline, in the KDIGO guideline, we thought the best data, at least in stage 3 CKD non-diabetics, was based on the subgroup of SPRINT, which showed consistent benefits. And I think that drove a lot of the blood pressure target in the KDIGO guideline, recognizing, which is not always done in practice, that you can only give a blood pressure target if you measure blood pressure using standardized blood pressure. And I think, that may be some of the controversy, because are you actually able to do that in all practices? But we felt pretty strongly that you can only really give a blood pressure target if you measure the blood pressure the same way as it was done in the trials. So regarding the new data are more data in patients at high cardiovascular risk, and also suggest that a blood pressure less than a systolic less than 120 is of benefit for cardiovascular protection. This is a little bit less applicable to patients with kidney disease because there's only small subgroups of the population in each of these studies that have CKD. So, perhaps consistent with the data in the SPRINT subgroup of CKD subgroup, these data are consistent with that, and also bring a diabetic subgroup with CKD and suggest a cardiovascular benefit. So how would I change my management? I would say I'm a bit more comfortable in both diabetics and non-diabetics, at least in stage 3 CKD, that at least try and get the blood pressure to 120, recognizing, if there are many individual decision-making that need to take place if you're on many meds and having side effects. Patients come to my clinic. Ali and I have worked together in clinic for years, and Ali's now in clinic, and, if someone's at 130, I'll often leave it where it is, particularly if they are on a lot of meds. But for cardiovascular protection, at least in this early stage of CKD, maybe this provides a little bit more data in the diabetic subgroup. So a long answer to your question. Hopefully I answered it.
You did. You did. What, including elderly, would you say, given our patient, the CKD population tends to be on the older side, and I sometimes I am a little bit more worried about driving blood pressures down, even though the data suggests that you can do so safely. I just often wonder whether the polypharmacy is worth it. For particularly looking at prolonged outcomes. I tend to go back and forth. How do you adjust your target for older patients? Or do you?
Yeah, I'll let Ali answer.
Sure. And Mark, please jump in. But I think we spend a lot of time talking about this because we do worry, in our older patients, frail patients who are already on many medications, how aggressive do we want to be? And, I think we try to make the point that really these intensive targets are helpful for patients who are at high cardiovascular risk, but we also have to take into account the other factors at play. So if we have a patient who we feel is at high risk of falling or some of these other factors, we may be less aggressive. The other point I just wanted to make, Mark mentioned, the in-office blood pressure measurement and the sort of standardized way that blood pressure is measured in these trials, which can be difficult to achieve, in a busy practice where maybe the sprint blood pressures, it's not feasible from a time standpoint to take those blood pressures. We often anecdotally talk to our patients about what their blood pressure is at home. And I was interested to know that in the BP Road trial, one of the 2 new trials, due to the COVID-19 pandemic, that was actually the first trial that we could identify where actually in-home blood pressure measurements were done. And, they tried to do them in a standardized fashion. But I think that is, so some of that data was collected from in-home measurements, which is of interest. But I think both of those trials, as Mark said, have somewhat limited CKD populations. The ESPRIT trial, actually, one of the exclusion criteria was, I believe, a GFR less than 45. So that trial, it has a pretty robust diabetic subgroup. But that being said, I think that some of the results may be limited to population with advanced CKD.
Would you say, I'm very struck by your difficulty or your acknowledgement of the difficulty in getting accurate office readings. I have to tell you, they are standardized or not. I would say they're completely worthless at the Brigham. Chime in here, Martina. It's just not done accurately. So I actually try to get as many of my patients as possible following it at home. Between the trials that targeted less than 120, did the new trial, I don't recall this detail, were there fewer medications in order to achieve the target BP based on home readings? Reasonable, because I would be absolutely over treating if I based my therapy on office readings invariably.
Oh, that's exactly,
That's a good question.
that's exactly right. If you based, you got to be careful for using targets of 120 if you're basing them on office blood pressure readings, because on average, most people are a little bit lower. So if you're targeting less than 120, they're going to go less, but a good proportion are going to go less than 110 at home and have more symptoms. Ali, I don't know if you remember, but I don't know the data on the meds that were used in that particular component when it was COVID and home blood pressure readings. I'm not sure if they provided those data, but they have big appendices that may be in there somewhere. But I don't. It's a good question.
Yeah.
How valuable that was. I think for all of us, it's going to be helpful in the future if some of the trials include home blood pressure as the target, or there are a few trials that have used ABPM as targets, but they're not big trials with cardiovascular outcomes, kidney failure outcomes, etc. But having more of that data and how to extrapolate it to the trials, of course, is always going to be helpful to us.
Yeah, there is some reluctance on the part of patients to monitor the BP at home. I suspect once they walk out of my clinic, they want to forget they have kidney disease, and I totally get that. That said, the value is immense in getting home readings.
One thing is regarding the clinics, we've managed to have our nephrology clinic function very well with everyone coming into the room and having 10-minute sprint blood pressure. We call it sprint blood pressure, just 3 standardized measurements. And that's just the standard of care in our clinic. Getting everyone in the hospital to do this is obviously complicated, right? Because the primary care physicians are in a rush, want to do a blood pressure and move on very quickly. And this is obviously the challenge with the standardized office blood pressure measurements. One thing that is kind of interesting is, there's all these financial targets, reaching blood pressure targets in primary care. If you use the standardized blood pressure measurements, you may do better from that standpoint, which some people have mentioned to me is how they've managed to introduce this into their clinics.
So there would be a huge incentive.
Right. It's all money.
Yeah.
Drives everything, right?
Well, Martina, we should almost certainly make a point to tell Joe and Eugene this. There's something to be gained.
Yeah.
I won't say which clinic I was in, but those when you interview patients and a question is, do you feel safe at home? Well, the nurse was interviewing the patient as the blood pressure machine was on. I could hear it clicking away.
Yeah.
And she was saying to it, do you feel safe at home? I was like, hey, note to self, disregard this blood pressure immediately. It's one of my most difficult.
Yeah.
I just in terms of the home blood pressures, I actually, lucky enough, I also have a part-time appointment at the VA, and we have a fantastic system where the VA supplies home blood pressure monitors to patients.
Oh, wow.
And we also have a really good telehealth system. So I get probably more access to home blood pressures than at the VA, certainly than I do at the Brigham. But one question, Mark, in terms of what we've seen from the trials and all this discussion around standardized blood pressures, what should be our blood pressure goal for home blood pressures, do you think?
Yeah, you can try and extrapolate some of these data. The problem is, this was one of the points that we made on the guideline. On average, the office blood pressure may be, I don't know, on average, maybe about 10 higher than your standardized blood pressure in the office, and you can have an equivalent home blood pressure. But to any particular patient, there's no equation. We spent like months saying, can't we have an equation that says to us, that if this is your office blood pressure, this is what your standardized blood pressure is, and this is how you extrapolate it. And there's no way for any individual patient to extrapolate what their standardized blood pressure is. You can get like averages. So I think Paul Muntner has kind of written about kind of equivalent targets, but again, if you want to do what's done in the trials, for any individual patient, it's not, you can't extrapolate perfectly. So I can't answer that question. I don't know if there's anything new on this recently. Obviously, the blood pressures are obviously getting done at different times. And is it the standardized in the office getting compared to the home? And how are they compared? Or is it someone doing a standardized at home comparing to your regular home? I think there's a lot of variability in all of this, but you'll find some of the, I believe some guidelines do mention kind of home blood pressures to target, but I can't remember the exact numbers for that.
But you target the extrapolation 120 systolic using standardized office readings. Am I?
That's what I'm targeting in my clinic. Yeah. Mm-hmm. So that's the one that I'm taking as the gold standard. Whether that's, their perfect blood pressure, that I have no idea. I mean, that's another discussion. Is that really the gold standard blood pressure? I don't know, but that's the one that was used in the trial that showed the benefit. So that's why I have to use that one as my steadying blood pressure to change medicines. And, what to do with the person who's between 120 and 130, that's a little complicated because the trial, even the sprint trial, allowed people to go above 130 before they were randomized. It didn't put anyone who was at 125 into the trial. You allowed them to go up a little, but then randomize them to 120 versus 140. So always a little bit of a discussion as to if you're already in that 120 to 130, is it of benefit to go below 120? I think that's another slightly controversial point.
Well, I think in BP Road, the achieved blood pressure was something like 133 versus 121. So effectively, it was blood pressure. They achieved blood pressure over and under 130 systolic.
Yeah, and that's similar to sprint, where they achieved, even though they targeted less than 120, I think they ended up at about 121, 122 exactly. In the low blood pressure group, and like low 130s, I believe, in the 140 target. So even the 140 target is gonna, be in the 130s. But they achieved good separation, it seems like, in both trials.
Martina, I don't know if you had any other questions.
In your editorial, you talked a lot about the fact that the low GFR patients are not enrolled in these studies. And obviously, dialysis patients are a whole other discussion in terms of target blood pressures. But for yourselves and in your own practice, how do you think about those patients who are CKD4, and where do you target their blood pressure and walk this line of risk of AKI and complications with the meds?
Ali, you want to answer? Or you want me to answer?
So I think that in looking at these trials, there was perhaps some evidence, and Mark, correct me if I'm wrong, I think that this was from MDRD maybe, where there was a lower risk of ESKD in patients with advanced CKD in that trial. And so I guess, I kind of think that there is probably benefit to getting the patients to 120 or below, but I think that it requires close follow-up because of that risk of AKI. So I think it requires a little more of a hands-on approach. And I think for some patients, if they're coming in and their blood pressure is in the 160s, I would worry about getting them down below 120 and that causing some kind of acute like hemodynamic fluctuations that would affect their GFR. So I guess that's sort of how I think about it. But Mark, what are your thoughts?
Yeah, I think that population is complicated. So in the patients with more advanced CKD, the trials all focus on ESKD as the outcome. And what we know is in long-term follow-up of MDRD and long-term follow-up of ASK, that intensive blood pressure may slow progression to kidney failure. Like in those studies who start off with low GFR, and particularly if you've got proteinuria. The problem is both of those trials are a little different, and we use the term intensive blood pressure in our editorial because there they targeted MAPS, and they weren't targeting systolic blood pressure, which adds a whole nother dimension to blood pressure target. So yes, I think you've got a lot of proteinuria, and you, even if you're in stages 3 and 4, trying to get that blood pressure closer to 120 to 130, or the maps based on the trials, to me would probably may slow the progression of kidney failure. And that's how we try to distinguish the outcomes in our editorial, both the cardiovascular outcomes and the kidney outcomes. And the data are obviously much better for the cardiovascular outcomes, at least in the earlier stages of CKD. So I think the whole area will continue to be a little bit controversial just because the way the trials have been designed. And we try to fit our blood pressure targets into specific groups who are not always included in the trials.
Just one last question, which you did not cover in your editorial, so feel free to deflect it. Would you care to speculate about dialysis patients' targets?
This one, we really don't know. Completely different population. And I think there's a reason that there's never been a BP target in any dialysis guideline. The last one, was like a level C or something for less than 130 in dialysis patients based on no evidence. So we really do not know in dialysis patients. I would say if the patient is tolerating ultrafiltration and not having intradialytic hypotension, yes, I would like the systolic less than 130. I think in the long term, it's probably good for the heart. If they're going to get a transplant in the longer term, it's probably good. But if you're starting to cause problem with the patients in intradialytic hypotension, Trendelenburg, all this type of thing, sometimes we have to let it start at 140 to pull off the fluid. So we really have no trials. The only trial actually that's been done was by one of our colleagues, Dr. Miskelen, and I can't quite remember the targets, like 130 versus 155 or something like that, and showed no benefit of like 130, and in fact, I think worse complications of access, if I remember correctly, in the lower blood pressure target. So yes, dialysis completely different topic, as it is for all cardiovascular risk factors and interventions.
Yeah, I think Dr. Miskelin's trial is discussed in this issue of nephSAP.
Oh, okay, yeah.
That's and we ended up. I was surprised at the recommendation on such a high blood pressure pre-dialysis, but the data certainly support that. So it was.
Yeah, and it's obviously a small trial, and it's doesn't have. I think the LVH was the primary outcome they were trying to achieve, and I think there was no difference, right? Yeah, that's what I remember.
Well, thank you. I certainly have no further questions. Thank you so much for spending the time with us. We really appreciate it.
Yeah, thank you for inviting us, and I think both Ali and I learned a lot because
Yes,
there's as you saw, the one table goes like 4 pages. So we wanted to share the data. It's complicated, but I think if someone's really wants to understand it well, they got to see what the data is and understand why it's a complicated topic, just the way the people have come into the trials, different targets, et cetera, different outcomes.
All right.
Thank you so much for having us.
Yeah.
Thank you.
Thank you very much.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.